very much. And I must say, the rebel in me is very tempted to go over time just to see the inaction of the eyebrows and the chip chambers flip, but I shall not do it. It is really an honour to have been invited here today to present the data from our E-Delphi study, and I know that many of you have taken the time, the little precious time that you have, to answer the study that I sent out. So the study was started in February 2017 and under the supervision of my research supervisor, Dr. Helen Lackman, who most of you know from UCL in London. And we essentially went through all the abstract book from the previous meeting from here in 2016, as well as all published cases of DADA2 that had been published in the literature, in order to find out what were the presenting features of this disease and what people were using to treat it, and to basically test the water and see what you were all doing and how you were approaching this condition. We had 69 respondents from the first round, and it was very, very long. It was 44 questions long, and I know it took you all a long time because the average time it took to complete the survey was 37 minutes, and to complete the next survey was about 14 minutes. So the round 2 was much shorter. It was very, very focused. It was 17 questions, yes or no, and we have some consensus, although most of the time I will tell you and give the game away that we have very little consensus on most areas, and I think that's probably borne out in the published literature as well. So we had mostly respondents who were paediatricians. Most people were physicians. There were certainly some people who were lab geneticists, and there was a medical student who responded to the survey who was doing a project on this. And 3 people had never seen a case of the disease, but most people had seen over less than 5 cases, and there were 2 people who had seen over 30 cases, so probably the most experienced people in DADA2 in the whole world. And it was a very large data set, and this is our data set for everyone's use, and you're welcome to ask me because I've had to cut down, obviously, the data that I can present in a 15-minute talk. And I've had to really cut it down. But not only was there yes-no data making consensus, but many of you wrote free text. And the free text is a real rich source of information about this disease. And reading it, I can feel your frustration. People are frustrated. They want answers. They're not sure what to tell their patients, people who are heterozygotes, who may have some subtle symptoms. And that's very borne out if you read the free text from our survey. We are going to focus today on the diagnosis of symptomatic and asymptomatic patients, as well as investigation and management. But I've had to cut the slides about follow-up out because it was just beyond the scope of the talk, unfortunately, but I'm happy to discuss it at any point in the next 2 days and show anyone the data that is interested. And screening of relatives I've deliberately kept in because I think that's a really important issue. So the theme 1 is diagnosis, and what this is here, and it's quite small, but as you can see, it's every single presenting sign or symptom in the literature. And so we asked you to choose which ones you felt, and the ones that felt to be most prevalent in the diagnosis of DADA2 were livedoid rash, stroke, fever, and digital gangrene, which all came out over 80%. So I think we have consensus in that these symptoms and signs make you think of this diagnosis, and cytopenias, hypogammaglobulinemia, and splenomegaly were about 60%. Okay, so they didn't quite reach the consensus mark of 80%, but they are definitely there. And I think this is a year ago, and certainly we're understanding much more about the hematological manifestations of this disease over the last 18 months, and perhaps if we asked you again, those would be slightly higher up on the list. And then we asked the question, what do you consider the gold standard set of diagnostic tests for DADA2? And I think this is really crucial because how can we do clinical trials if we can't decide what the diagnosis is? And most people have responded, over 80%, saying it is the gene sequencing and enzyme activity together, which is quite interesting as we go later on, because you can see that people, I asked the question, and I don't know if it projects, but in B, that is homozygotes, so 2 mutations or compound heterozygote in CRCR1 gene, as well as low serum ADO2 activity. But people really didn't feel that if you were heterozygote, that you could have this disease at all, unless you had low enzymatic activity accompanying it. In addition, we asked the question, can a true heterozygote have the disease? And some people felt yes and some people felt no. We haven't reached a consensus on that, and there were many other similar questions that were case-based and asked this question in other ways, and they all came out with the same answer, which is just over 70% felt yes. Most of the time that's in context with a suggestive phenotype, but if you put in low ADA2 activity as well as a heterozygous mutation, it goes right up to about 85%. But can you diagnose the disease if you do not have the facilities in your laboratory or available to you to do it? So actually most respondents, as you would imagine, because people that were asked were already involved in the DADA2 community, most people can access gene testing. So you can see that about 70% can access the genetic test, but by far the majority of people cannot measure the enzyme activity, and yet they're saying that it is crucial in the diagnosis of these patients. So we have a bit of a conundrum there, and that needs to be worked on. So if we move on now and skip forward quite a lot of data to investigation and management of these patients, we asked, what baseline investigations are you doing? And there is absolutely no agreement on what is happening. Okay, so there are reams and reams of clinical questions that you may recall answering, trying to look at this from every different angle, but basically there's no standardized approach to the investigations of these patients worldwide. So respondents to the survey come from all over Europe, the Middle East. There are people from quite a lot of respondents from the US, many people in the room I can recognise today, and there is no consensus there at all. It is the case that I've looked deeper into the data, most people who are not routinely doing invasive angiography or cerebral imaging at all are paediatricians, and that makes sense to me. I'm an adult rheumatologist, I see a lot of vasculitis in my clinics and I use imaging a lot, but with children I wouldn't be as keen to do that. So we don't have consensus there. Now, we asked in the event of an acute event of DADA2, and by that I probably mean stroke, what treatment would you give? And most people would give steroids. I think that's by far the majority, coming up to 90%. And then we see that most people would also give anti-TNF. A few people would go for upfront bone marrow transplantation, and we'll hear more about this over the course of the meeting. And there are some people would give fresh frozen plasma, which I suppose has scientific plausibility. And then we asked more time, my preferred first-line treatment for DADA2, which would be anti-TNF, and most people were either responding anti-TNF or anti-TNF plus steroids together. And no one at that point put an upfront bone marrow transplant, which I thought was interesting. And we asked about the long-term treatment. And as you can see, the big box in the corner, which is in yellow, is anti-TNF. And this is almost at 100%. So most people would give anti-TNF. And I think we can say that there is a consensus that that is the treatment that we would prefer. Of interest, no one gave cyclophosphamide, which is obviously the traditional treatment we would give for very serious vasculitides. And that's not given at all. No one put that. And some people are using mycophenolate mofetil, and a lot of people are using steroids, but the preferred longer-term treatment is anti-TNF therapy. So then I asked, what type of anti-TNF? What are you using and how are you dosing it? And the vast majority were using etanercept due to its pediatric licensing and experience, but people also suggested adalimumab because of the decreased frequency of injections, which is certainly a consideration, and some were using infliximab due to its IV preparation. And increasingly, and I work for the NHS, and we are under great pressure to actually give the cheapest biosimilar drug. So, but as far as I can tell, there is no data on biosimilar use in this condition. So I asked, how long would you give it for? And it looks like you all want to start it, but no one wants to stop it. And I think that is basically what this data shows. So indefinitely until more information is available was over 70% of respondents. And then we look at lifelong. So I think those two together are probably say the same thing, and that's about 80%. And then I asked about housekeeping things. What do we do to mitigate their cardiovascular risk and their thrombotic risk? And actually no one is anticoagulating. So I think that's quite clear. Nearly 100% of respondents would not give formal anticoagulation, even in the context of an acute thrombotic event. And antiplatelet agents also are not in favour amongst people who responded. I asked about statins. There only would be given if it was indicated by lipids and not at all in the paediatric population. And people are routinely screening for hypertension in these cases, and they are treating it if they find it. So theme 3 is relatives, and this is where we really have no consensus at all. Okay, really none. So there's a slight consensus in that in the current practice, some people are doing genetic testing on all patients, but there is also a wide discrepancy on who and how they are being investigated. And if you can see from the below table, it shows that people are either screening parents only with genetic testing, some people are screening parents only with ADA2 levels, and some people are screening patients and their siblings and all the relatives they can get their hands on. And then I asked, well, do you routinely refer these people for genetic counselling? Because how do we interpret these results? We don't have consensus on it, that is clear. And so who is supporting our relatives and patients through this myriad of decision-making that even none of us know the answer to? And there is quite a big availability of genetic counselling. I was surprised, and about 30% are regularly doing it in their clinics. And then there are others who don't have access to it but would like to. I think we could work on this a little bit better. And so finally, I asked, would you follow up asymptomatic relatives with heterozygous mutations? Because I think that's really important. And most people said yes, but actually not a vast majority, so 56% said yes, and the rest said absolutely not. We don't believe that this is the disease, and there was lots of free text about it. And then I say a third category, which is yes, please, for research purposes, because we don't really know what this means. And if we have access to the patients and time, we should be looking at them, in my view. So in summary, we are very far from consensus. It is crucial for clinical trials that we have a consensus, at least on the diagnostic criteria, so that we can make sure that patients included in these studies really do have the disease, and that no one can argue about that. It is crucial for patients and relatives to understand what's wrong with them, and I think meetings like this is really moving the field forward substantially. In addition to that, we have seen that livedoid rash, stroke, fever, and digital gangrene are highly suggestive of diagnosis of DADA2, and I think probably everyone here agrees with that. And gene sequencing and ADA2 activity levels are not available to all, but that would be considered to be the gold standard at consensus so far. There is no consensus about true heterozygotes and whether they have disease and whether they even need any follow-up. There are a wide variety of practices for baseline investigations, and I think that's something that we could quite easily standardise amongst our community. And I think anti-TNF treatment and steroids were certainly reaching nearly 90% consensus agreement to treat to patients with, and I think that's very positive, especially when you work in an environment like I do, where it's very difficult to access these drugs, and we're increasingly needing to provide an evidence base in order to get it funded. Anticoagulation and antiplatelet agents are not given routinely by people who responded to this survey, and screening, investigation, treatment and follow-up of relatives, there is a huge variation in practices, and at that I will leave it. Thank you.